Thank you. So I'm Aaliyah Runyon from the American Medical Student Association, the Education Fellow, and your presentations were amazing. And I kind of want to continue the discussion because as I was listening, I was thinking about how AMSA always thinks about leadership. We train student leaders in areas of medical education, health policy, and advocacy, and we're always thinking about these types of questions. Something that comes to my mind is kind of the trajectory of how we train health profession students into health professionals, and how it is very much this lone learner philosophy. Like everyone needs to have a good grades, good scores, that kind of thing. And this is always like this is important in terms of competence, but then kind of the larger question of how do we cultivate these kind of social justice advocacy, social contract values earlier in education, and then continue them into nursing school, medical school, dental school, whatever the health profession is. And then in that way, I'm thinking maybe there's at that level, if this is cultivated early, there's a better way to have those professionals work together because this has basically been a part of their education since early development. And I'm just wondering what you think about that.
All right. Some comments?
One of the things to think about, and we think about the social contract and justice, and I think that's important, but we also want to be sure we remember effectiveness as well. And so I'm beginning to sound like something out of Dickens, but I don't mean that. I mean that we can get preoccupied on the other side of thinking about social justice, which is really important, but we have to put it in the context, always in the context of all the other stakeholders who are involved here. And I think sometimes we don't do that.
I would say also that exposure is important. I think giving students the opportunity to work with different populations, with different cultures. I know I did a research project where I interviewed African-American drug users, and nice people. I really enjoyed it. I mean, it was a good experience to get to see other people's perspectives and to really, some of the stereotypes that I might have, I think can really be turned over by just simply exposure and getting to know people better at a personal level.
And I think the other thing is to work on these projects in interdisciplinary teams to make sure that, every possible time, especially in training, that different disciplines are working together towards, say, a QI project or a community health project or whatever it is, that we don't do our training, preferably not our education, but I think some of that has to be done separately, but the training really is interdisciplinary, and we learn from each other.
I think one of the real challenges in terms of the silo model is that education is very much constructed in a silo model, that here's this department or this school, here's this other department or school, and it, other than with the use of technology, the getting together process is quite difficult, and I think that is a real challenge that higher education needs to take on, is how to make that work efficiently and effectively. That it's because we don't have all the time to be spending on a lot of logistics. We need to be able to figure out how to bring students together in meaningful ways throughout their educational process, not just at the end, saying you'll get it when you get into clinical practice, but we need to be able to do that. And our structures don't support that well at this time. And our abilities to use technologies well to help that process, I think, are just beginning to evolve.
Point. As students, you should go talk to strangers, talk to people who aren't in your department, not in your area, who don't teach you. Do that yourselves, because we're not always going to be able to do that for you. So go, if you're not in public health, go talk to the public health people. If you are, go talk to the clinicians. Talk to the people, talk to the managers in a healthcare organization. That will give you other perspectives. So kind of do some of the work yourselves.
I add just one thing also, that I think it's important to teach students a bigger picture about health disparities, especially in this country and throughout the world, because a lot of my students come from upper economic, socioeconomic levels, and they just really don't have a clue. And until you see what those disparities are, you can sort of maybe start to identify more with social justice issues.
Yes, another question?
Thank you. So I was thinking about Dr. Cox's question yesterday of building a big tent of professionals and the potential erosion of individual identities going forward, which I think is something that we need to come back to. But then, Patricia, I was struck by this idea of the Creole and this sort of common language, and that perhaps the big tent or the individual professionalism is maybe the wrong question. Maybe the issue is, what common vocabulary or Creole can we all agree upon? And then I was thinking about the idea of the social contract, of justice, of disparities and inequity. And could it be that the social contract or equity, justice, fairness, efficiency could be the Creole that we all agree upon? I just wanted to put that out for the panel to respond to.
I just say yes, but then you'll find different professionals will prioritize those differently. And that discussion is very rich discussion. Yes, good. Sorry, and the healthcare managers may have different perspectives.
Yes.
So I wanted to comment too on the Creole concept, which I think is a powerful idea. But my question is, who do you see as the linguists, the conveners, the people who are going to bring this together? Because we're full of concepts, we're full of ideas, but we're short on action. And I think to get the action piece, we need the linguist equivalent. And so I wonder if you've given any thought to that.
Yes, and you won't like the answer because I wrote it in an article but I think I'm wrong. But that originally it was going to be at the ethicist, because of course that's what I do for a living. But not necessarily. I think, for example, it actually could be an organizational leader who has broad enough thinking to try to figure out what was going on in her organization. It could be one of the your leading of healthcare professionals in an organization. It could be a public health person. It certainly could be someone in the social work, someone who would take that leadership position to see and realize that they don't know everything. I think that was another good point. None of us knows everything, but it has to be someone who has the insight that I don't know everything and I don't quite know what you're talking. I don't quite understand your language, so I've got to figure that out. So I think there are people, not just ethicists, who could take that leadership. You have to look around to find those people, or maybe some of you in the room have to take that position. But I think most of you could do that because you know you have a good broad sense of the system and what you don't know. So I think it's just a matter of taking some leadership on that.
I think there are individual and perhaps organizational linguists in the sense that you're describing. I was thinking more of a national linguist. I mean, how do we do this on a broader scale? Because I think there are many examples, small examples, and maybe that's the answer, bubbling these small examples up. But it would be wonderful if there was some sort of national or transnational way of dealing with that.
Institute of Medicine.
The global farm? Yeah, I was going to answer the local question. I do think that psychologists on teams often function in exactly that way, noticing when people don't communicate well with each other and what their different languages are and trying to put the patient at the center of care and pull people together. I think that it's not very different than family therapy.
I think there was a comment here.
Yes, I wanted to comment on the idea that you are training managers in professionalism, and we talk about training individual students, but we're also talking about our collective responsibility as professions to come together and try to negotiate around these things. And I'm wondering what you see the role of the disciplinary societies. Everybody in this room represents a society of members. And I'm sure not all of our members are in agreement with some of the things that we're talking about right now. And what do you see as the role of professional societies in this change process? You're asking me?
Comments from any of our?
Go ahead, Susan.
Well, thinking of our professional society, I mean, I think it's key. I think that we have to really influence through education, through leaders, through inspiration, through projects. We have to get our own people on board about this, and not everybody is, like you said. But I think if the leadership of professional organizations can come together and make agreements, it does have the possibility of influencing the people on the ground. I think it's really important. You know, you have a bully pulpit of a certain kind.
In terms of bioethics, at one point there were several different societies. There was a Society for Bioethics Consultation, there was Societies for Health and Human Values, and I think there was another one, and they all came together and formed the American Society for Bioethics and Humanities. And I was thinking when you asked the question about sitting down and how do we, work through this process, there's a concept in anthropology where we talk about the negotiation of reality. And it strikes me that this is possibly what happened with these societies, is that they sat down and maybe not through, but maybe through a process of discussion, they sort of negotiated the reality that came out to this final product.
I wanted to just put out there again, because Susan spoke first, and she made a comment back to the idea about students and really educating for the future. And looking, she made the comment about how are students selected for admission into programs, and how are individuals hired into organizations, and what are the skill sets that are looked at and valued in that process. And I didn't know if there were any comments to in that regard as well. Yes. Are you one of our students? All right.
This is a little bit of a random comment, but I think it addresses your point. I'm a second degree student in the nursing program, and it's been an interesting experience coming from having worked in different industries, including business and teaching, and I was an anthropology major the first time around. I think that offers us a lot of, a lot of perspective that's different than people who come up in a healthcare field starting kind of at age 18. And I think my vote would be for trying to make that happen more, have students have experience in go out and spend a year doing something before starting whatever healthcare profession.
Just to comment, maybe everybody should need to take anthropology too. I was an anthropology major. It seems to be a link. But I sit on the medical school admissions committee. I have for a number of years now, and I see how we're changing. We are changing what we are looking for in medical students, much more in line with the values and the behaviors that we're talking about now. And there are a lot of different ways to try to look at that, and we do select for people who've gone and done other things, preferably international things, preferably service things, in addition to research, et cetera. Where I'm seeing less of this happen is in hiring faculty. Selection committees for leaders sound very different than the selection committees, the admissions committee I sit on. And I think we need to try to do something about that. It's very hard, but I think we're still selecting for traditional autonomous leaders who don't necessarily have the competencies we're talking about of transdisciplinary professionalism.
Okay. Yes, comment?
I really appreciate the panel and the perspectives that have been presented, but the one thing that struck me more than anything else was the compelling nature of purpose as a basis for bringing people together, and the situational character of the Creole, that in some sense it wouldn't happen unless there was something meaningful that needed to happen together that was clear and wasn't in the abstract. It was very much in a moment and in a defined way. And I am a little concerned, and I think I will leave this meeting probably more unsettled in my perspective than settled, because I wonder the extent to which we abstract what we're trying to achieve in ways that may actually distance ourselves from our students and their need for purpose and their need for reality. And perhaps it is the skill of convening at the moment and bringing people to a common ground that's purposeful that is more important than telling them how to believe or what to think. And I'm just wondering how we grapple with that and how we make our teaching actually more connected to the realities and to associating with mentors and colleagues who actually can convene and bring that dialogue into its application.
That's part of why I wanted to show you the video of Lauren and Ian and how they came to all that they talked about. I couldn't really tell you exactly, but they absorbed something. And I was very struck with them talking about issues of meaning, issues of helping each other, making each other better at what they already do, the importance of the patient. You know, a lot of those things, they just sat down for 5 minutes and that's what they talked about in terms of their work together. So on the ground, I think it can be very meaningful.
Yes.
I think one of the things that I've been listening to for the last 2 days is, and it's refreshing to hear us talk about mixing the students up. But one of the things we're not talking about as much is mixing the faculty up too, so that we're working with each other's students. Many years ago, once upon a time, there was grant money that helped us with this, and I was a faculty member on in the new family medicine, and I'm a nurse practitioner in the new family medicine department at Hershey Medical Center. And we had a grant to work on this kind of thing, and we developed a course, and they put me in charge of the course, so that was how much trust we had. But what we did was, it was with first and second year medical students. We did this in small groups, and it was basic stuff. It was interpersonal communication skills, family life cycle, physical assessment, those kinds of things. And each of these small groups was led by a team of faculty that was made up of one male and one female, and one of those people had to be a physician and the other was a non-physician. And it was a very effective way of teaching everybody about each other and getting people to recognize that this should all be collegial and that we're not supposed to be fighting with each other. And of course, the program went away when the money dried up. But we've been here before, and I think we need to think about those things again.
Yes.
I appreciate the inclusion in the panel of someone from management. In 2005, the Joint Commission held a national conference as a follow-up to the Bridges to Quality Report, Health Professions Education. And they explicitly included healthcare managers as part of the dialogue. I think what it does is move us from an individual and a team framework to a system level. And I wanted to offer a proposal for what belongs in the center of your last diagram. In 2001, there was a follow-up report in the British Medical Journal that the first author is Don Berwick, and a group met at Tavistock, and they refined and offered 7 principles for everybody working in healthcare and those receiving care. And I think as I called up those principles this morning on my laptop, and I think they crystallize a lot of what we've been talking about from a systems perspective. And they include, this panel included a number of ethicists. The titles are Healthcare Human Right, Balancing Patient-Centered with Population-Sensitive, Comprehensive Management, Disease Burden, and Promote Prevention. And this is inclusive of responsibilities of the healthcare system. Professional collaboration is another one. Quality improvement, safety, and openness. And so they offered 7 principles, and I think they made some attempts to get to work with systems around these principles, and it's disappeared, and there's a fairly recent commentary that you can access through any of the search engines on what happened to these principles.
What's the 2001 reference?
It's Berwick and others. It's called Refining and Implementing the Tavistock Principles for Everybody in Healthcare. It's British Medical Journal, 2001, volume 323, 616 to 620.
That's great. Thank you.
All right, yes.
Thank you very much.
I'll just keep going on the Tavistock principles because I think this touches back to some of what Pat raised around, and also Jackie, around exposing challenges in conflicting values. The Tavistock principle, and it also exposes a little bit some of the very practical stuff that I think we're trying to get at in terms of next steps, actual next steps, not just talking more about values, but what would this actually look like in implementation. So folks in bioethics will recognize principlism as a way of thinking about moral philosophy. And it was itself a compromise between people who really believed strongly in deontology, rules-based Kantian reasoning in terms of moral philosophy, and people who believed in consequentialism, Mill and utilitarians. And between the two of them, they were constantly arguing about what the right thing to do was, because there was a consequentialist way of thinking, which is, means justify the ends kind of thinking. And there was always follow the rules, and everyone could think of an example where one of those got the wrong answer. And principlism was supposed to be a middle ground, which both deontologists and consequentialists could buy, because the principles were autonomy. Who could be opposed to that? Justice. Who can be opposed to that? And everyone bought the 4 principles or 3 principles, or as some people sometimes say, the 1 principle: autonomy, 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 and there was one more. But in any event, the reality is having 4 principles or the 7 principles of Tavistock doesn't actually get you to an answer, because these principles in practical reality conflict with each other. So the interesting conversation is about which principle matters when and to what extent, and why do some groups and individuals see one principle as governing in a particular situation while others see a different principle as governing in a particular situation. So the interesting thing and the important thing is the ongoing nature of decision-making by principlism. And so that's number one. It's an iterative, so this gets us back actually to what we were talking about yesterday. The nature of professionalism is not a one-off. It's an ongoing conversation between members of the professions, the public. It's an ongoing iterative process. Tavistock fell apart because it didn't continue. Laying out principles is not enough. There has to be an ongoing process. There has to be a structure. There has to be social infrastructure for maintaining the conversation over a long period of time. And that's the second piece of this, is what is, and maybe I'm just reiterating the question that's already been asked, but what is the social infrastructure that's necessary to maintain this dialogue, to maintain the ongoing, so within medicine, which itself has lots of disciplines, we have the Council on Ethical and Judicial Affairs. We have our principles. There are 9 of them. They conflict. And we have a process whereby we look at these principles and bring the deliberations to the larger body. It gets voted on. Sometimes it gets approved. Sometimes it gets sent back. In society, we have processes for these. This is the justice system. We have a Supreme Court. We have ways of, of using the infrastructure of society to get at what are our core values and which one matters in this instance and which one doesn't. I don't think we've got that infrastructure in healthcare yet, where all of the disciplines, all of the key stakeholders, not a term I love, but stakeholder theory in business might be helpful here. So something about getting everyone at the table to carry on this ongoing discussion. That wasn't really a question, was it? It was more of a statement.
And so with that, I'll let the, help the transition to the education piece, so that if there are any final remarks from our panelists that reflect on that and how that might be influenced as we look at education. Any final remarks?
I agree.
All right, thank you.
And can we give our moderator a round of applause as well? So we now have a 20-minute break, not 30, but a 20-minute break. So I'll be ringing the chimes in 20 minutes, actually 19 minutes. And could I get the next set of speakers, the group leaders up at the podium for just 1 minute? Kathy, Susan, Meg, and Mary Jo. Thanks.